It's a real pleasure to have you here. Thank you, Greg, for helping in organizing this really unique event. We have the opportunity to have the best thinkers in the world of functional and female urology gathered here in Chicago because of the AUA, and I have a really privilege to have them among us. Thank you also to Dr. Kovac, who's going to help me in stimulating their brains in the morning. Let me just briefly introduce who do we have the honor to have. It's, the first one is going to be Dr. Blanca Madurgo, who is a professor of urology in the University of Cádiz, beautiful town in south of Spain. And she is the National Coordinator of Female and Functional Urology in the Spanish Urology Society, organizing incredible educational events, and basically she formed almost half of the Spanish colleagues that are dealing with pelvic floor dysfunction. We have another star of the Turkish Continence Society. As you can see here, he is the real TV doctor, Turkish TV doctor, which is not Dr. Ross, is Dr. Tarcan Tufan, professor of urology, giving his interview here at CNN. He's the current president of the Turkish Continence Society. And another giant here among us is the pharaoh of all the urologists, pharaoh because he is actually from Cairo, Egypt. He's the general secretary of International Continence Society. This event is also going to be podcast for the group of people from South America that are dealing with pelvic floor dysfunction, which is called ALAP. Esto es un saludo para los miembros de la Asociación Latinoamericana del Piso Pélvico. So, the title looks a little bit provocative here. And this is not meant to be as a Spanish Inquisition, and this is in honor of Blanca, who gave me a great idea about how she was perceiving this whole event. But it's more like this guy from my country, the Renaissance view on the new spring on the use of the Urodynamics in the current time. And what we're going to do, I asked all three of our guest speakers to answer this question in their specific areas. Why and if should we do the urodynamic examination? When should we do this examination? And how often should we repeat? We're going to start with Dr. Kovac presenting a case challenging Dr. Blanca Madurga, and my question is, can we make it a little bit simpler, this evaluation of patients with female lower urinary tract symptoms? So here is a case that Dr. Kovac prepared for you.
I want to thank Ervin and Craig for inviting me to this. This is truly an honor to be included in this group. And in preparing for this, Ervin and I went back and forth, and I was like, oh, I have all these slides prepared for it. He's like, you have two. 2 slides to present the anti-urodynamic position to kind of state, where we are with urodynamics, and maybe stimulate some of the discussion about how we can improve testing in the long run. So let's take an easy one. A 43-year-old female with 3 vaginal deliveries with a 1-year history of loss of urine with cough and physical activity, now requiring multiple pad use daily. She has a past medical history consisting only of some well-controlled hypertension, no prior surgical history on examination. She has a stage 1 cystourethral and has loss of urine with cough during your physical examination. So the diagnosis is obviously stress urinary incontinence. And while AUA and guidelines optional, the value trial pretty clearly indicated that there was no benefit to urodynamic testing at a 1-year post-operative interval, and both the American Urogynecologic Society and the International Urogynecologic Society have stated that urodynamic testing is unnecessary in patients with uncomplicated stress urinary incontinence. And I suppose the uncomplicated becomes the key word in that question. So the next issue or controversy is a little bit more problematic. And we'll take that same 45-year-old. Now we'll give her a stage 3 cystocele and urodescensus who comes in complaining of mild urinary urgency, but without any obvious stress urinary incontinence. The traditional dictum had been to do a reduction urodynamic testing where you reduce the cystocele. However, the reliability of that testing has never been shown to be good. Weber et al. In 2000, so almost 20 years ago, showed that preoperative urodynamics does not improve cure rates for urinary incontinence in this setting and is not cost effective. The Opus trial estimated that you'd have to do almost 6.5 slings to prevent one woman from needing future incontinence surgery. So you would expose over six women to unnecessary slings and the potential morbidity of those slings, which we all know is there, to prevent one patient. Furthermore, John Wynn found that 2/3 of women with prolapse and urgency will resolve spontaneously with the correction of the prolapse, again taking away one of the other planks for doing urodynamic testing in this setting.
Thank you, Bill. So, Blanca, please, can you...
Wait. This slide, please, because I need you to remember this war is 19 years ago.
So, Blanca, now you're going to try to convince us that we are wrong. And I know that you can put all your Spanish fuego into it.
Okay, first of all, I want to thank the organizers of my meeting for asking me to be here today. Thank you very much. I'm going to speak about the need in the urodynamic study in female with POP or incontinence urinary. The question is it necessary? And the answer is yes, always, of course. And for demonstrate that, I make and explain you the guidelines. Okay, the European guidelines for 2019 say don't routinely carry out urodynamics when offering treatment for uncomplicated stress urinary incontinence is the first in clinical case. But say to preliminary urodynamics can influence the choice of treatment of the urinary incontinence, even though preoperative urodynamics in women does not improve, of course, the outcome of surgery of the stress incontinence. But it fails conservative or drug therapies. Maybe we can offer urodynamics if in my chart choose the future treatment in stress, mix, and urgency incontinence. Okay, the NICE guideline published in April 2019, last month, don't recommend the urodynamic study before preliminary surgery, of course, but yes, when there are urgent and predominant mixed urinary incontinence or which the type is unclear and will have voiding dysfunction made with anterior or apical prolapse and in recurrence after surgery. And what about the American guidelines? Okay, the same, not for the first surgery, but in women with high-grade POP, but without symptoms of stress urinary incontinence, is necessary. Okay? And we can make the urodynamic study with POP reduction to assess for occult in stress urinary incontinence, and I think very important, the detrusor dysfunction. We need to begin to speak about the underactive detrusor. Okay, this is a document from the United Kingdom Continence Society, and advice make urodynamic study prior to surgery for bothersome stress incontinence in women with POP and urinary symptoms before surgery, and women with new onset post-void pelvic floor surgery. That is very common. Maybe because before some people don't do an urodynamic study. In women with voiding dysfunction and urinary rotation, and when failed overactive bladder treatment before Botox or neurostimulation. To summarize, we can make a urine flow study and post-void residual urine to screen for low flow prior to stress incontinence surgery in women with voiding symptoms. To screen for voiding difficulties in women, including women with possible obstruction to the POP. And when we make a standard urodynamics, a complete urodynamics study in women prior to stress incontinence surgery, maybe we can discuss that. But yes, always in women with voiding symptoms, and when they are refractory to conservative and medical therapies. And now here you are a small bibliography review for to know, compare, and unify criteria. I think it's very important. In this work, made urodynamics before and 6 months after surgery, and the conclusion are cerebrospinous history and associated vaginal wall repair do not affect the bladder function either subjectively or objectively, thanks to urodynamics. In this work, conclude too, the laparoscopy sarcopexy, support without detrimental effects urinary function. They know that because made urodynamic before and after surgery. And there are a lot of work speak about that. For instance, in this preparative urodynamic parameter could be useful in providing adequate counseling to facilitate decision. That's important too. The detrusor underactivity every time is more and more common to find that. In this work, showing a 41% of detrusor underactivity in women with POP. It's a lot of women. And in this, I love this because preoperative urodynamic testing for urinary incontinence and pelvic organ prolapse can resolve change the treatment plans. Okay, for taking home message, the urodynamic study is a good test, reliable and objective. In 20 minutes you can make an exam and it's not so expensive. Maybe it doesn't change the surgical option, but sometimes it does. And the first surgery always is the first surgery for a woman. We need to be sure before. Very important in clinical trials for unifying criteria and can help the outcomes. And very important for me, the most information we get regarding previous labs may help us to agree with our patient about treatment option and to reinforce the doctor-patient relationship. Thank you very much.
Thank you, Blanca. I think there's a space for discussion about when. So you answer why should we do this, but you didn't answer in which patient should we do this type of evaluation. We're gonna stimulate you a little bit later with everybody else. Now, I have another pleasure to introduce a guy that I know from few months. This is just to say that I don't know how many decades we know each other, but I'm going to challenge Tufan Tarchan to talk about when should we use urodynamic in male lads. This is, for instance, a typical example for whoever doesn't eat urodynamic every day. You can see a mess. All this, I like when Nadine presents this type of cases. She's very excited because it's very colorful. You have all the traces going up and down, and say, finally I have something. But the nightmare and the headache again to me. So how can I read this? What can I do with this information in a patient that has urgency, frequency, nocturia, weak stream, and he leaks because he had the radical prostatectomy. So how is this type of information helping me in my decision-making process? Why don't I just use my medical skills and obtain other information, or use just the imaging, for instance, for this patient? This is one of my most favorite pictures I took in Tufan's hospital. So why can I just look like Dr. House and using this type of knowledge rather than just an expensive test like urodynamic is? So please, Tufan, can you give me an answer to this?
Thank you very much, Ervin. Well, good morning, everybody. It's a great pleasure and honor for me to be here. I would like to thank first Professor Niederberger and Ervin Kocjancic for organizing this beautiful meeting and under this marvelous architecture. It's a really great privilege for me to be here. So Ervin asked me to answer these two important questions in 12 minutes. I will try to do my best. And of course, the disclosure is classical, but my greatest disclosure here that I'm a member of the Urodynamics committee at the International Continence Society, and our slogan for this year is "Make Urodynamics Great." So I'm sorry if this reminds you something else, but what can we do? So, oops,
This is breaking it.
yeah. So the two questions I will try to answer this morning is, first of all, do we need urodynamic studies in patients with male LUTs that are suggested for benign prostatic obstruction and for urinary incontinence after prostate treatment, as we traditionally call post-prostatectomy incontinence? And my last slide is actually here. Yes, of course. Well, I don't need to remind you that male LUTs is has a let's say etiology, multifactorial etiology. We don't deal just with the prostate, and this has caused, as you know, a paradigm shift in our guidelines. For example, in the EU guidelines, we are not talking anymore about BPH. In the AUA guidelines, we are still using the word BPH, but I hope this will change because this is just a histopathological terminology, but still now they have added the importance of male LUTs. So definitely we are not just dealing in this patient population only with the prostate. And I would like to remind you that our goal of the best patient care goes to understanding first the pathophysiology, and we need, of course, to have a good patient counseling. And this is gaining more and more importance, and especially, for example, even in Turkey, now medical legal issues are becoming more and more important for us. So it's not just only the question, as they have asked in the value trial, so does this change our final treatment? Well, this is not an enough question. We have to also ask other questions, like what other additional treatments may the patient need after the operation? So I think we have to be honest, and we have to be consult all these with our patients preoperatively. I took this picture from the AUA this year. This is a quotation from the guidelines of the British Society for Sexual Medicine about testosterone deficiency, and it says guidelines can never replace clinical expertise when making treatment decisions for individual patients, but rather help to focus decisions and take personal values and preferences and individual circumstances into account. So when we are talking about the guidelines, we have to remember that they are not the holy book. So, but still, let's have a quick look at the current guidelines, starting with the AUA. The AUA guideline about male LUTs says that urodynamic studies should be spared to the patients who have male LUTs attributed to BPH when diagnostic uncertainty exists, but the details are not explained. The EAU guidelines give a little bit more detailed information. However, all recommendations are weak. First, when the patient has a previous unsuccessful, especially invasive treatment, they are prone to urodynamic studies. And if you plan a surgery on a patient, and if the patient has a voided volume consistently less than 150 milliliters on uroflow meters, or a Qmax more than 10 milliliters per second, or a PVR higher than 300 milliliters, and age over 80 years, then urodynamic studies are warranted. Well, all recommendations are weak because there are no RCTs. This is not the failure or mistake of the urodynamic studies, but since we do not have RCTs here, we cannot make stronger recommendations. And this is actually indicated with the level of evidence 3, the lack of RCTs in this issue. And the Cochrane review in 2015 said, although invasive urodynamic testing did change clinical decision making, we found no evidence to demonstrate whether this led to reduced symptoms of voiding dysfunction after treatment. This is again a lack of research. Well, we know unfortunately that not all our patients are doing well after surgery. For example, 11% of the patients after surgery fail to void. In one study, it was found that up to 28% of patients were catheterized on discharge, and continued medical therapy is needed in more than 50% of the patients. And we know not all our patients who come to us with male LUTs are obstructed. In this study by Ervin, according to the Schaeffer grade, only 37% were found to be obstructed. Is obstruction important? Of course it's important. We know that obstructed patients do much better compared to the unobstructed patients after surgery. So another factor that can be revealed by urodynamic studies is, of course, detusor underactivity. And we have the evidence at the level of 3 that detusor underactivity is a worse prognostic factor for failure after TURP. And another urodynamic factor that we can find out is detusor overactivity, especially when the detusor overactivity occurs in the initial phases of bladder filling. This is a very bad prognostic factor for urinary incontinence, also the need for anticholinergic treatment after surgery. So if we just evaluate patients who do not do well after the TURP, we see that only a minority of them are obstructed. But in the rest of the patients, the failure of TURP is related to bladder dysfunction. So as the list of take-home messages, I would like to, actually, I don't want to repeat because of the time limitation, but we have to do pressure flow studies in certain selected patients, and these are, as of today, very well delineated by the EAU guidelines. And let's very briefly look at the post-prostatectomy incontinence cases. We here face a very interesting dilemma because bladder dysfunction is seen in at least 1/3 of patients with PPI if you do the urodynamic studies. But interestingly, we say that, or Ervin says that, this is not reflected to our results in surgery when we treat these patients. Now, please stop here. This is something that we have to explain. So again, when we look to the guidelines, we see there are no RCTs, and okay, urodynamic studies do not show to have a yield here, but again, the level of evidence is very low, and we cannot make strong recommendations here. And if you look to the literature, these studies are just single cohort studies saying that urodynamics does not predict outcome of surgery for PPI. And everything appears to be weighted against artificial urinary sphincters. I may agree that artificial urinary sphincter is a gold standard treatment. However, it's not the best treatment. It's not the optimal treatment. Why not? Because actually, if you ask the patients after the surgery, you see the continence rates are not as good as we report in our papers. For example, pad-free rates range from 10 to 7, even to up to 2% here in these patient groups. Mechanical failure, urethral atrophy, infection vary between 8 to 45%, erosion in 70 to 17%. And if you ask the patients preoperatively which procedure you prefer, and interestingly, slings are preferred by the patients against artificial urinary sphincters. And does the urodynamics influence the outcome of treatment of PPI here? Well, we don't know because there are no RCTs here. And the answer to this question from the evidence-based medicine's point of view is unknown. ICI in 2017 indicates that and says urodynamic studies should be performed when there is post-prostatic incontinence going on after the conservative measures and other conservative treatments are failed. And urodynamics for patients in this patient group is not just to show the stress urinary incontinence, but to reveal bladder dysfunction that is behind. And interestingly, detrusor underactivity is quite common in that patient group. And in 1/3 of the patients, they go together with an anastomotic stricture. Well, since after our replacement, the patient with detrusor underactivity can void with Valsalva, it doesn't appear to be a big problem for our patients. However, we know that these IHAV patients after Maceling surgeries who undergo retention because of detrusor underactivity. So detrusor underactivity appears to be a problem basically for the sling patients, and I wouldn't do a sling operation without any urodynamic evaluation. So in summary, there's an urgent need for RCTs. Detrusor underactivity is an issue for Maceling, but maybe not, we don't know, for our replacement. Well, detrusor hypocompliance should especially be suspected in patients who leak at night, especially during sleep, and a risk factor for failure after sphincter replacement. And these patients should receive first treatments to treat their hypocompliance. And it's still not clear what the bladder dysfunction plays a role in the treatment of PPI because we don't have in good quality data yet. Thank you very much for listening.
Maybe to find you just, you realize that you are going home from here with more homework to do for your committee in the urodynamics, no? Because you're just showing us how far are we with the knowledge or lack of knowledge. Let's now end with another topic that is very controversial. So this is when we put this on the program, and speaking with Sharif, he said there is no brainer. This is, if we need a urodynamic, this is for neurogenic patients. All of the neurogenic patients, when I was trained, when I was in your shoes, guys, here, this was like a must-do. In any neurogenic patient, you just automatically go for urodynamic examination. However, look at this recent publication. So, the urodynamic is so unpredictable. And it's so unreliable in measuring the function of the lower urinary tract. Works perfectly in the detrusor overactivity. But everything else, you need something more than just the urodynamic. So why bother? Do I really need urodynamics to evaluate the detrusor overactivity in any patient? Can I just do this with a well-done modern voiding diary, like you can see there, combining maybe with some imaging? So the question to Sharif, why do I have to work so hard to place all these patients, paraplegic, tetraplegic patients, onto to the urodynamics? I can obtain the same information in a much easier and a more comprehensive way, like in our fishing session here. So I'm going to give the podium to Sharif now, who's going to try to convince us that urodynamic is a must in the...
Good morning, ladies and gentlemen. I again want to thank Dr. Ervin for organizing this very interesting meeting. And also I want to thank Dr. Craig for the professor and the chair of the department for this invitation. Actually speaking, being the GS of the ICS, not only the Urodynamic committee, I have to be very fair and clear to you. Urodynamics, I'm not here to say that it is a must. On the contrary, I'm very happy to say that it is an option, because urodynamics shouldn't be done for every single patient, and that's what we'll see now from the guidelines. Although I hate guidelines, like Tufan said, it is not the Bible, because your expertise is very important. But the guidelines is like when you raise up your kid and you think that you are giving him the best thing, and tell him, this is my guidelines to you, my boy. And then he will keep doing his life normally, and sometimes he will think about your guidelines, but then he might be better than you, and he might be maybe more creative without your guidelines. So guidelines have to be in the back of our brain to go to it when we need it. The same for urodynamics. Urodynamics is an option to us, but sometimes it makes our life easier. Like for example, if you're starting to drive, like this morning, and you live here, but sometimes you just, shall I go right, left, which is more traffic? If you go to the GPS, it can guide you, it can make your life easier. So this is the urodynamics. It makes our life easier, but sometimes we don't need it. Sometimes not. For example, out of the 100 TURPs I do, I would need urodynamics for 5 to 7 of them out of the 100, which means that it's not very important. And even for stress-free incontinence, if the patient is really a straightforward case and hasn't been operated before, I wouldn't do urodynamic. But it is beside me. I will use it when I need it, and I will feel happy and covered and shield. It's like a shield for everything. So let's start with, for example, giving the case of neurogenic body dysfunction in a patient with MS. How would you evaluate the patient if medical therapy is not effective? For example, after giving her medical therapy and then she's not happy, or maybe the post-voiding residual is increasing. You need to know what is going on. You will not keep giving antimuscarinics or offering Botox or whatever without knowing. What should you do if the post-voiding urine is increasing? Is it the trusor atonic, or will it be the trusor-sphincteric dyskinesia? What would you decide to inject Botox or to perform neuromodulation without urodynamics? You need, sometimes you said, okay, I need to be shielded with this. Would you decide diversion or augmentation without urodynamics? You are taking a serious step here. So sometimes you feel like, why not? In Parkinsonian disease and bladder outlet obstruction, for example, do you think knowing the level of the outlet resistance is important before deciding a TURP? Is it at the sphincter side, or is it really the prostate and you need to tunnel or whatever? How would you evaluate the degree of the trusor overactivity only with the history? Sometimes in these patients it is not accurate with the history alone. How do you evaluate the sphincteric problem? Is there any bradykinesia with the sphincter or not? So you need sometimes to have it. Again, I will go to the guidelines to make myself very clear and short. And these are the most 3 important guidelines that we use. The ICI, we have the 6th edition, last one. Next one is next year in Las Vegas. And we'll have the 7th edition. And the AASUPO guidelines and the EAU. We'll go shortly with the 6th edition. As you can see here, that the findings of urodynamics tests can be difficult to anticipate from the clinical assessment alone, which is true. But as you can read, that it's a combination of EMG and imaging adds diagnostic possibilities, and the filling rate also can help pressure development of the bladder and the sensation. Everything in the urodynamics can help you. And this is the recommendation that there is currently inadequate data to support recommendation for the use of urodynamics in each specific neurological condition. However, the use of invasive urodynamic recommended in neurological condition associated with high pressure bladders may place which may place renal function at risk, as opposed to urodynamic safe bladder condition. So this is the recommendation that in cases that it's really critical or uncertain, you will need to do a urodynamic. So it is still there and very important in some cases. If you go to the AUA and SUFU, the part of the urodynamic bladder, so they said clinicians should perform corresponding residual assessment either as part of a complete urodynamic study or separately. I will not go through the whole thing, but then clinicians should perform a complex cystogram during the initial urological evaluation of patients with relevant urological condition, and should perform again all this in the evaluation of patients with relevant urological conditions, and when available, clinicians may perform fluoroscopy at the time of urodynamics, with urodynamics, which is very important to diagnose the true sphincteric dyssynergia. And also they should perform EMG in combination with the filling cystogram, with or without the pressure flow studies in patients with relevant urological disease. So urodynamics in the guidelines is still there, and if you look at the EAU again, they are showing that urodynamic investigation is necessary to detect and specify lower urinary tract dysfunction or function, and same session repeat measurement is crucial in clinical decision making. So all the guidelines are still showing the need for urodynamics. I will not go in reading one by one because you have this all in your hands. So three important guidelines are mentioning that urodynamics is still a very important tool in the diagnosis and the final decision in some critical neurological cases, not in the very clear ones. So you're still there and it's still needed to use it in the critical cases. This is a very important one. This is the classification system done by Helmut Mansbacher. I don't know if you know Helmut Mansbacher or not. He is the president of the INOS. INOS is the International Neurological Society, and Helmut is like the father of urology in the world. Is that right?
He's like the King Tut.
Yes.
Because of his age as well.
This classification that has been used by the European Society in the guidelines. So they are mentioning this classification in the guidelines, and it is based on urodynamic study. So it is very important to classify neurological bladders and urethra and sphincter with urodynamics. And as I told you, this was a very important session that Helmut was teaching Ervin how to do urodynamics and the importance of urodynamics, and I think that Ervin was a very good listener to this. So again, how would you deal with obstructive LUTS and Parkinsonase, irritative urinary incontinence and urogenic bladders, psychotherapy reflux due to spastic bladder, female stress urinary incontinence, MS, pelvic organ prolapse, spinal cord injury, meningeal seal, bladder augmentation, and urinary diversions. All these conditions will be critical and medically legally critical if you don't put a urodynamic proof to what you are doing and what decision you are taking in them. So thank you for your attention.
They did a pretty good job, but I'm still not that convinced that that's the way to go. So I would ask all three of our speakers to come back to have a seat here in the Inquisition table, going back to Blanca's definition. Please to find Blanca. And I have the honor to have among us also some friends that are very actively doing urodynamics and big believers in urodynamic studies. So we have friends from Italy, Elisabetta Costantini, a big friend of our department. We did some studies with us. Elisabetta is here. We have Dr. Kumar. It's a friend from and colleague from Weiss Hospital. So I invited you to cheer Bill a little bit because he felt a little bit alone, he being the only gynecologist in the audience. And we have we have Dr. Vass, a great surgeon and urologist in an underserved area of the world from Mozambique. So I'm pretty sure that we have some questions for them. I would really advise you to ask questions before I ask questions, because I can be very, very nasty and provocative. So, Bill, are you happy with the answer that Blanca gave us?
Well, I think what I really want to know is how can we better assess the hypoactive bladder and use that data to change our surgical outcomes. That's been the striking challenge I have dealing with that aconic bladder.
But the iconic bladder matters in these patients. If you have a patient with severe incontinence, she's leaking like, I don't know, 5 pads a day, almost a liter in this. Do you really need to have a urodynamic to fix her sphincter?
I need, for first, I need a urine flow plus phosphoric residual urine pressure. If that is normal, that means there are high residual urine, or the maximum flow rate is normal, I don't need, of course, a complete urodynamics. But if there are something wrong, I make urodynamics.
So this is you're raising a very interesting question. So what is a urodynamic? So because when we're talking with the residents or with nurse practitioners, let's do a urodynamic. What does urodynamic mean? Do I have to go really through everything? Cystogramograms, pressure flow studies, urethral profiles, EMG, or can I just do like clinical urodynamics? So put my clinical knowledge into this scenario and then just have, I don't know, Euroflow and one flag, Euroflow and PVR. Sharif, what do you think about this?
It depends about what you are looking for. For his question, he was asking how to diagnose underactive bladder. Is that right?
I'm asking how we can find a hypoactive bladder setting in a prolapse, and how we'll adjust, how we'll change our
To define this, you need to look at the bladder contraction. If the bladder is really contracting and there any increase in the pressure during voiding or not, so this one will need pressure flow study. If you have symptoms for overactive bladder, so you can just do filling cystometry. And it's according to what you really need to know. Sometimes the free flow, the simple flow without pressure flow study is more indicated than the pressure flow study. So for example, you can do Euroflow for the male patient and it is quite normal and with very normal bed shape curve. But then during the pressure flow study, it is less due to the catheter inside the urethra. So you need to look at all these things and correlate it with the symptoms.
I have a question for Tufan, who is eager to answer. We know that a third of female normally, physiologically, void without any contraction with the uterus. So how can we use this information clinically? So how can I reproduce the urodynamic finding into the clinical scenario? Tufan, can you help us? You're the subcommittee, the urodynamic committee of ICS.
Thank you, Ervin. This was actually the point that I would like to bring up. Women do not need a good contraction to void, especially the ones with the incontinence. So it is possible that we may face retention for that reason after increasing the outlet resistance after our surgery. So this is really an unanswered question, a big field of research what we have asked. Still, we do not have good parameters and definitions in women to define obstruction and that is underactive. That's a big problem. And in urodynamic studies, at least 1/3 of women cannot void with the catheter inside. So this is a great issue, but it doesn't say to us that we don't have to do urodynamic studies.
Then also, the other tab doesn't work because it's very embarrassing to do this in front of 10 people watching. So do you have a question?
So we were talking about pelvic organ prolapse and high-grade pelvic organ prolapse without stress urinary incontinence. In that setting, we were saying that urodynamics is required or recommended. what do you think about doing, instead of that, a retrofill cough stress test with the prolapse reduced clinically? Is that a way to avoid it?
What do you mean retrofill cough stress test?
Retrofill a bladder with 300 cc.
Well, because there was a study, there was like a urodynamic testing that's paid the best of time doing this thing, just measuring the pressure. But did you get the question? So why can I just make it simple? Rather than getting squeezed into that car with beautiful caries, why can I just fill the bladder, see the leak, and then operate the patient?
I think the urodynamic study is obligatory before the POP surgery. And it's better if we can do that with reducing POP before. Okay? In our work, I find there are 41% women with testosterone underactivity. This is very high number to make a surgery without anything. The urodynamics not improve the result. Of course, that is a good diagnosis.
So I have another question on this. So you said that this 40% of women have underactivity. So would you not offer a product surgery to them? They are bothered by this bladder at the knee level. They have underactivity. So what would you just you would not operate them?
Yeah, no, I operate.
So why are you doing it?
But I operate, but I can't speak before with my patient. I say, you have this problem, and probably you continue avoiding dysfunction. But you are right there, your sexual function, for instance.
So now it's a very interesting and important concept that Blanca is raising. So we are using urodynamic also to manage patient expectation after surgery. I know that Dr. Aker.
We know that majority of the guidelines speak against the routine utility of UUS in uncomplicated female stationary incontinence. And I'm not so convinced by the definition of this. So how would you define uncomplicated female SIU, and how frequent are they in your practice?
So I think this is a question that we need another hour of discussion. I'm going to go this way. So a very short answer, all three of you on the same question, please.
For me, they do not exist. I mean, uncomplicated stationary incontinence does not exist. There is no index patient for it.
True.
Usually, according to these guidelines, they define this, but by patients who didn't have previous surgery, they don't have voiding dysfunction or signs of overactive or overactive bladder symptoms. So these are what they define, where you don't need to do urodynamics before the surgery.
I don't believe in uncomplicated stress urinary incontinence.
This was the shortest. I have a question. So we have a pleasure to have Igor Vas. We are trying actually to do some cooperation, and we were invited to visit his center in Mozambique, and one of our residents is very eager to do this. So, is he going to see urodynamic in your Mozambique practice? And how are you managing all these uncomplicated, complicated, no index patients in your everyday practice without the urodynamic?
Yes, in fact, we have bought the machine, but we still not
using
it because of staff. We don't have staff to carry on.
So what are you doing now?
Now I'm just doing evaluation. I do ultrasound. I'll do the residual evaluation, how they void it. I measure the flow and see if it's a good flow without any residual, probably hypertonic bladder. But instead, we have some cases that failure CRP, that the patient doesn't empty completely the bladder. But, then you cannot do anything even after the urodynamics.
Well, you can keep doing QRPs. This is what actually happens in our practice. So, but you are raising a very interesting concept, which is the clinical urodynamic. The urodynamic is not, and this is, I say to all my residents and all my friends and all colleagues in the ICS, urodynamic, the urodynamic testing was used for me to understand the physiopathology of the lower urinary tract. Once I get this, I don't need to re-perform this study so often, because I'm using this in a clinical fashion. I use a lot of thinking before offering this urodynamic, because yes, it's not expensive, but for the patient is, it is very expensive. There are a lot of costs. Your time is there. And for the patient, it's not really that pleasant to have to cut the slacks in their body and everybody staring at them. So what do you think about this clinical urodynamics? So you're thinking, your urodynamic thinking in addressing the patients. You actually mentioned this.
Yeah, first of all, and you have also mentioned in your introduction that voiding diaries are very important. These are the cheapest urodynamic methods in our hands. And plus, talking about urodynamics, we have to confess that 60% of urodynamic studies in the world, even in the famous centers, are not performed respecting the ICS standards. In fact, a good urodynamic study is very reproducible. So, but to clinical urodynamics, first, every patient before undergoing urodynamics should have a very good voiding diary.
Sharif.
I agree with Tufan about the voiding diary, and if it's complemented with free uroflowmetry and post-voiding to the urine, then you got like 90% of what you need out of the urodynamics. But then you will be confronted with some few cases like this. Post-operative, you need to know if the bladder is contracting or not, if the obstruction is still there. So very few cases, and then you can decide.
Blanca, what about those patients that we were saying before? Patients that has a huge prolapse, you measure an underactive cruiser, and they can actually, some of them, they just start urinating normally after correcting the anatomy. So why are you still offering the urodynamic in these patients?
Okay, first, the prolapse or incontinence surgery is a surgery of quality of life. It's functional. And we can make a surgery for our patient will be worse. And it's important, the previous diagnosis. And first, if the urine flow study is normal and the patient having high residual urine, I can make a urodynamic study flow complete. Only urine flow study.
The other question is, who should do the urodynamics? Should we, as physicians, do it? Can a nurse do urodynamic? Can you read the result? Can a student do it and we go drinking coffee? So how is this done in Turkey?
Well,
Because
there are different answers according where you are working. I'm lucky that I'm doing my urodynamic studies all by myself. So
I'm doing it myself in one center, and this is now it's very time-consuming for me, but I have one nurse only in Cairo that can help me, and she does it accurately and professionally, and I just go to write the reports. But she has to be very well qualified to do this.
Right.
I work with a nurse specialty in urodynamic study, functional urology, and study medicine.
Can I add just one sentence? The urodynamic study should be performed by the person who knows the patient, who knows what he's looking for.
Very true. So I'm also lucky to have a nurse practitioner who's working with me. I would be completely lost without urodynamic study. So, Nadine, what do you want to tell to these experts? Do you have any questions for them? Should they go home and we can keep doing what we are doing?
Hi, my name is Nadine, and I have a question about the, I'm sorry. So when a patient comes to you with an overactive bladder symptom, when she or he's been on so many anticholinergics already and already on anticholinergic, do you really need to do a urodynamic then? Because you know that person is already responding partially, maybe 50%. So would you go ahead and do urodynamic on this person? You know is responding to anticholinergic already?
This is a great question. So can urodynamic help me in identifying if the patient is the Botox versus neuromodulation? versus tibial neuromodulation versus tibial implanted neuromodulation? That's actually
After failure of
medical
medical.
treatment.
Yeah, because this, you mean the refractory overactive blood.
Yeah.
You have to go from the least invasive to the most invasive. It's like sequel and like this. And then after the failed medical treatment, there is always a stand, whether to do Botox or neuromodulation.
Yeah.
And it depends upon what you have.
Do you use Urodynamic for that decision?
Yes, after failure of medical, there's some time before attempting this, I do this.
I like the way how you're measuring your words because you went from yes to sometimes, now we're going to know which.
No, I tell you why. I think it's because if this patient had the urodynamics before starting, and I know how severe its symptoms, and it didn't go, so I repeat the urodynamics again.
Tufan, what are you doing?
Yeah, I'm always doing in the refractory cases urodynamic studies before I proceed with Botox or neurostimulation. Although again, if you look at the literature, it doesn't matter for the Botox success whether the patient has that sort of overactivity or not. But it doesn't change my policy.
Blanca, what about you?
Compliance is very important. I have to be sure with compliance.
Blanca, what are you doing in Spain?
In Spain, I made urodynamic study before neurostimulation, but not normally prior Botox.
So thank you very much. I think this was a fantastic panel. This is a quality panel that I will put on any of the educational events that I organize. I used to organize for the ICS, so I do have the same disclosures as all these three members have. We are all in agreement. We are all doing urodynamics when it's needed. So this is my criteria for doing urodynamics. I used urodynamic when I was a resident to understand what I was dealing with. And I'm using urodynamic when the case is so complicated that I'm just lost. So when I start thinking like Dr. House, which is the best doctor I ever encountered, he knows everything, and he solves everything with the deep brain biopsies. So when I started going off the track, I use the guidelines as an orientation. I am not a big believer in following guidelines blindly. There's the reason why we have a brain, and we should use this, and the reason why we have a knowledge, and we should use it. But when the things are not as clear, I think the urodynamic evaluation is very, very helpful. So I want to thank our participants. We are a poor state university, but very appreciative. And I have a small little document of appreciation to you. You have a beautiful USC AirPods, so you can listen some good music on your way back home. You can also, when you go back to your institution, you can change your holders of your badge with the USC's one. You're going to remember us, listen to these phrases. And for the final memory, I have a certificate of your being such a valuable business professor in our university. So thank you for coming. Thank you for sharing your expertise with you. And as you all stay here, the breakfast is, you're now allowed to finish your breakfast. So thank you very much. Yeah, can you take a